Great, welcome back to the House Healthcare. So, all right, now it's time for a committee conversation on 766 with the full acknowledgement that there's still pieces we have to go through. So next week, section 1, we will be, I think it's next week, going through. So let's jump to section 2. And I am going to take these independently because although the whole intent of the bill is to streamline and reduce provider burden, they are pretty distinct sections. So section 2 is the claims edits that we just were talking about. There are quite a few suggestions for language changes, which, I still think there needs to be an agreement between the insurers and the provider stakeholders, but I feel like there's some movement to come together. And then there may be some areas where they're not coming together that we'll have to make some decisions on. But I guess any overall comments, thoughts, how we proceed on the claims edits? Topper.
I would recommend that we have the insurers, the providers. Anybody else?
Maybe someone from the committee? But stakeholders, that's fine. Yeah.
Yeah, stakeholders get together and come up with some recommended language changes that bring you all together and stays with the intent to reduce the administrative burden of the providers. Is that something that you people would like to do?
That's not look over to you. And is that something our committee agrees with?
Yeah.
If they're willing to do it, okay. Yeah. I think that's a good idea.
Okay. So does anyone on the committee want to kind of be a point person through that process?
Other than Alyssa?
Alyssa?
You're the
I
only
would recommend.
thing about it.
Okay. And then, yes,
Do we
would you
need
like the
a-
healthcare advocate to be included?
No, but I could say just the word.
Yes.
Healthcare advocate, Mike Fisher, healthcare advocate. I did sit in on a meeting that already took place and really just as a bystander, the healthcare advocate doesn't. In this one.
Okay.
But I think they are, whoa.
Seems like it. Yeah.
Yeah.
Which is great. Okay.
How long do you think that would take?
Yeah, early next week.
Wednesday,
You're just saying section 2.
just section 2.
Thank you.
And I do not know Jen's availability, so we'll have Alyssa check in with her on how she can be engaged before Wednesday, or if we just take them to her when the time is right. Okay. I guess with that, I just want to get a kind of a sense, this is not a vote or holding you to anything, but we all agree that this is a good path forward on the claims edit, but we do need to move something forward.
You don't want chaos like we had before. No more chaos.
Okay.
But you gotta let the experts do their expert thing.
Yeah.
That's what I think.
Yeah, right, so let them come together. Okay, so then we go to section.
Would we like to include sections, the ones that Jordan
Yes,
regarding contract amendment in
yes, that would be great. So that was
Discussion
section
as well.
5 and 6.
Yeah.
All right, so 5, 6, and 2. And next week, when I'm like, what did we decide? You can all say, read your instructions. It's on page 12. Okay. Okay, so 2, 5, and 6. Okay, so now section 3 is on page 10.
I have a note that says, that both insurance companies agree with this section.
I think they agree with part of the section. All right, so yeah, so this is prior authorizations. I think they've all said that they, I have to look at my notes. Our understanding of the timeline, 24 hours for urgent, non-urgent requests.
Page 12, the 90-day thing was that issue.
90-day thing was at issue. Thank you.
Days for everything.
Great. So there's a couple sections, I guess, on prior auth. Yeah, okay. So let's hold on section 3 and come back to that. Section 4, which is also prior auth. This is actually a area we as a community discuss. So this section is saying Department of Financial Regulation shall adopt rules, bulletins, or other guidance that prohibits carriers from imposing prior auth requirements for any generic medication or for any admission item service. So basically, this section is saying we want DFR to review the prior auths that are allowed in the state of Vermont and make a determination for any category that has low variation across healthcare providers or denial rates of less than 10%. So this is kind of the section where we're saying we want to limit prior authorizations in Vermont with commercial insurers. But we've heard from both DFR and Green Mountain Care Board that they are not able to do this work. Okay. So along with that, we've heard that Medicaid has eliminated a lot of prior authorizations, and we've heard that utilization hasn't increased, and that although they haven't reduced staff, their staff is doing more meaningful work, I think is exactly what Candy said. So this is going to be a policy decision for us to figure out, one, do we want to limit prior authorization requirements by commercial insurers? And if we do, how are we going to do that? Since how it's suggested in the language is not going to happen.
You want to have that discussion right now?
We can put some ideas on the table.
Throw out some.
So wait, first, does everyone understand that
Which section are we on that, in that?
we're in section 4,
Page 12.
the very top. So section 4, little I 1.
Which a big note that it needs to be reworded.
Well, it needs to be more than reworded because DFR will not do the work.
Okay.
And Green Mountain Care Board will not do a work. And it's appropriate that they
One,
say they're not doing the work. So the first question is, do we as a committee believe, based on the testimony we've heard, that we should be looking at what prior authorizations commercial insurance require?
I think when we heard from UVM, they had 70 people working on prior auth.
Mhm.
So I think that there was a need to streamline it. I would say that that would be my position.
Yeah, and it wasn't just UVM, it
Yeah,
was
that
pretty
was
much.
a number that stood,
Yeah.
like, just jumped out at me. So I
Did
think
you
that
say
there's
17?
76.
Oh, so sorry.
Yeah, so I remember that number because it was so large to my
What's
mind.
interesting about that is that Diva has 5. So if we could use Diva as a benchmark, which I think came up, to sort of integrate their process to the commercial world, that might be useful.
So that's an idea. Yep, Brian?
Just that when I started my private practice, mental health providers had to do prior authorization, not prior authorizations. So maybe it's the wrong thing. Maybe I'll give these. We used to have to do this. I don't know what it was called, where like, you probably know the word better,
I think it was like a pre-approval.
or after, or like the
Yeah.
continued treatment.
Yeah.
So like you would get like 6 sessions, and then you'd have to like fill out a form, and then you'd get like 6 more, and you'd have to fill out. But the thing is, they never denied them because you could always make the case in psychotherapy why you needed maintenance. And it really didn't help treatment. It was an excessive thing and it got eliminated. I haven't had to do that in a long time. So I just use that as an example of how there was a practice that existed that stopped because it was excessive you know, I don't know if that's why it happened, but it was creating excessive burden. But when it stopped, it improved the delivery of care. And so similarly, if there's ways to eliminate unnecessary, you know, like processes that providers have to go through, like we were hearing how like the doctors will do it until they get it because they know the patient needs it. So they're just going to keep trying till they win. Then like if that's the case, then maybe there's another way to check accountability than prior authorizations. That's what I'm trying to say. That makes sense.
Yep, makes sense, Mari.
The words that have low variation across healthcare providers, that's hard to measure. Denial rates of less than 10% is not. So it's just a comment to be helpful to be as specific as we can.
On what?
What does low variation mean?
All
It
right.
says and denial rate, so it would be both.
So I'm hearing generally, and if there's a different opinion, this is the time to speak, that we do want to keep looking at I'm sorry, before I say what I'm about to say, do you have a question?
No,
Comment.
yes, I do have a question.
Okay.
I maybe in the interim, geez, it was good too. But I agree with what you just said, that we agree to do it.
Okay.
I want to say that I agree.
You agree that we
But
should
there
do
was
something? Okay,
something in it that I wanted to, I don't know what it was, but.
Okay.
Yeah.
great. So that's what I was gonna say. If there's anyone who doesn't think we should be moving forward with trying to do something with prior auth, let's talk about that. I just want to make sure we're came to be in general.
I know what it was.
Okay.
This is the crux of it here.
Yes,
isn't it?
this is the crux of it. Yes. Like
Okay.
the timeline, so the section 3, where you were saying the insurance companies mostly agreed.
Yeah,
I think that's secondary to section 4. So we have
Yeah.
to find a method
Yeah.
to do it and then agree on the timeline.
I know what I really want.
Okay.
Is there a statement like this that maybe other states have adopted? I wonder.
Yeah, no, so we actually just met, we just happened to meet with the Council of State Governments, and I asked the health policy person to do some research, and I mean, maybe the providers know something different, but I think there's a lot of ideas out there, and I think there's some attempts, like Texas tried to do it and passed a law, and sorry, Texas, I'm hearing it was a disaster. So no, there's not like a well-crafted, proven way of doing it.
Well, I think we really need to watch our language here.
Yeah.
I think it has to be very carefully done.
Melissa and then Leslie?
So I want to comment, the very first day we had our walkthrough, Jen Carby sat there and she gave the history of everything that the legislature has tried to
Yeah, that seemed like
do
a long time.
over umpteen years around prior auths. There have been studies, there have been committees, there have been apparently
Pilots.
pilots that have never. And my intent in putting this bill in, and I said this last time around the other, is we've really got to decrease administrative burden. It's a real issue.
And I think we've heard that from a lot
And
of
we've heard
providers.
that. And I really want to do something meaningful, particularly around prior auths, because I think we keep kicking the can down the road, and I think this is the time we need to do it. And I'm not sure I love all the language, but we heard in testimony something that I wasn't expecting to hear in testimony, which is I think we already have the roadmap. We have the roadmap from DEVA. And DEVA is already doing this work. They've already eliminated massive amounts of prior authorizations. They have a committee that meets every, I think it's monthly or like every 2 months, some period of time, in which they scrutinize what they continue to have prior auths on. They look at utilization. And then they look for anomalies in that utilization to see if it's explained. And then they come up with very clear, comprehensive reasons for why they're going to require a prior authorization. This work is already being done. And as I said before, a few minutes ago, one of the best ways to reduce administrative burden is to align as many payers across doing the same thing so that you know what you've got to do and you don't have to play this guessing game. We talked about the prior auths. The first witness we had, it's a game. It's all a game. And everybody has a different game and everybody's rules for playing the game are different. And I think we have a roadmap with DIVA. So I would like to maybe redo this section of the bill to essentially say all payers need to align with DIVA.
Which I think is, Leslie, what you had said.
Yeah.
Yeah.
Yeah, I just said it,
So
so
that's-
like an extra 10 minutes.
Yeah.
It's okay, it's fine.
Brief it up.
Getting ready for the floor.
It's your bill. I don't know where the bulk of these codes live, and you would know that. But I'm wondering about a mention of primary care in here somewhere. To think about really supporting primary care. And I don't know if it's appropriate, but I think a lot about primary care and that burden.
Yeah, I think that's one of the main focuses of the bill.
Yeah,
Absolutely.
I would like to see something about primary care.
And we do have the intent language. The intent on page 12, 3, section 4, 3, that, it's the intent of the General Assembly that we blah, 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 blah.
Yeah.
Frequently used meds, services, especially those ordered by primary care providers and achieve consistency. And if you look at the prior authorization requirements that DIVA maintains, most of those they have a list of like high risk procedures. Those are not things that are being prior auth by primary care providers. And they've eliminated, advanced imaging, which is huge. I think they eliminated anything around mental health.
MRIs, even.
They don't require it anymore on MRIs, CT scans. So if your patient comes in and you suspect appendicitis, you do not have to send them to the emergency room to get that emergent CAT scan. You can order it yourself.
Okay.
Yeah, that's it. So I think the intent that DIVA is doing is already getting to that
Yeah.
primary care.
And so are you comfortable with the way primary care
Yeah.
providers in that? Okay.
Sure. I just want to make sure I'm comparing apples to apples here, because as we said, UVM has 76 coders. DIVA has 5 coders. DIVA has 200,000 subscribers. UVM, I don't know that number but I don't know if they compare, but I just want to understand that connection.
So I think when we come forward with a policy goal that we're doing around prior authorizations, we will have that. We'll make sure we get that answer.
Thank you.
Just carrying on a little bit further, what's it talked about? Shall we bring together on that committee that DIVA has, bring payers, bring providers together with DIVA on that committee and have them all make decisions together?
That's an idea. I'm not sure we can require that, but
We can't.
but let's-
We can
How
ask
do
if they
we
would
do
be
it?
willing to do it.
yeah, exactly. How do we
Because to
do it?
me, if you do that, you get all the people impacted by it.
Right.
And they can come up with what they think is appropriate.
So I think us having this conversation is alerting the people in the room. That's one option that we want to do. And so think about that. I also want to make sure that we did ask Blue Cross Blue Shield to answer some questions about their prior authorization process. And I want to make sure that we give Blue Cross Blue Shield the option to come back and talk about those questions next week. So I like the way we're all going. I mean, I think we all kind of agree we need to move forward. We need to standardize. We have an idea out there that they mimic Diva. We have an idea of how we would maybe do that. So let's have Blue Cross Blue Shield come back in and MVP if you want to and look at what you're denying. We specifically have asked Blue Cross Blue Shield to come back and like, what are the denials? What are the broad categories? Love to see the same thing from MVP. I can send you the questions if you'd like. And then I say we have another small committee, unless someone, I mean, it's the same committee. So maybe we have Alyssa and then one or two other people from the committee. Also then work with the stakeholders on prior auth language. Art.
Yeah, and I didn't have it in my notes here. What were the private insurers feeling on 4? Did we get a sense that they were, did they ask what to do this, or was it?
I think it was a, yes, let's do this. But let me see what my notes said.
I don't have-
That was the one with the 30 million net, right?
Right.
I know there was a question about dollar value instead of 10%, and I know there was the word any generic on line 6 was
I didn't like generic.
Yeah.
a question that, but I don't know what the overall feeling was.
I think I'm gonna,
And I'd like to hear that,
Yeah,
because
we
this
will.
is critical.
yeah, so I think we will. I think the issue is we can't do it the way it's written.
Okay.
So
All right.
do we as a committee want to find a way forward? Great. Let's put an idea out there or two. Let's have the insurance companies and providers think about it and come back to it.
May I make a suggestion? I would love to have Mari work on this
Okay.
with me.
If she wants to.
Only because, I mean, there's, I think we have to think about prior authorizations in at least 2 different buckets, which is medical and pharmaceutical. And I think because of formulary issues, the pharmaceutical issue is going to be a little bit different to tackle. And,
I almost brought up formulary issues and then.
and so I think it would be wonderful to have Mari work with us on that.
Yeah, I was not gonna volunteer because I want to get ready for H 233. I think it's fine.
One that needs.
So you yes, sir.
Sure.
Yeah.
I didn't mean to volunteer you.
No, it's
I just
okay.
wanted your
Right, we need to.
Yeah. Okay. And I am gonna give everyone that's sitting around the outside of the table a chance to comment, so. Okay, so right now we have a little subcommittee working on, and we can add more people to it, working on sections 2, 5, and 6 for claims edit. Sections 3 and 4 for prior auth. So then the next section, which is what we heard about, I think this morning, it seems like it was days ago, is cost sharing, collection of cost sharing. Which I think this is the section that has the most, I don't know what the right word is.
Disagreement?
Disagreement, I guess is a good word, or like, can we even do it, right? So is this a fully baked plan type of thing? So I would love to hear people's comments on this. Brian, and then Alan?
I'll start by like aiming high, knowing this idea is probably gonna crash, but I feel like what this illustrates is the problem with cost sharing in general and about the problems of having like a multi-payer system. Like maybe the solution would be like some kind of working group to look at how to work towards a healthcare system where we don't have cost, where we don't have cost sharing, or like, it's somehow part of some, universal system or something.
Thank you, Brian, for that.
Alright, so,
Let's try a great idea, but let's stick to like the bill.
well, I guess a more realistic working group, it might be like, what if a small team meets and sees if we can come up with some kind of compromise between the providers and payers to see if there's something we can do in this bill to ease the burden of cost sharing on everybody?
Or what?
Yeah.
I don't want to say a study group, but is there a group that needs to really
Yeah.
vet this? Alan, and then Art?
Well, I just listening to everybody talk this morning about section 7 and hearing all their concerns. I hope that maybe we can rewrite it somehow, but I don't want this to jeopardize the rest of the bill.
Thank you for that. Okay. Art? anything,
Yeah,
Maureen?
and I feel somewhat the same. To me, I take this section out and have it be separate and let's go with the other uses that are kind of more of a slam dunk. This is, to me, I think we should take it out, but that's just me.
Maureen, and then Leslie?
Does this include the copay accumulator issue?
Yes.
So I think I would like to move forward with it. I like the idea of a small group, and I'd like to also invite the Office of the Healthcare Advocate, because they are in contact and they're working with a national group or more than one, or are aware of and communicating with. So I think your office, I'm looking at, for the record, Mike Fisher, would have some helpful input.
Leslie?
So what I took from our conversation was that the providers support section and the insurers do not. And
And not that they just do not, but that it would be
unworkable
costly for them to
unworkable
implement.
was the word used. But I would like to try, and see if we could get in a room and see what could happen. Or some of us or whomever, at least give it a shot. And before we just not.
Okay, Melanie?
I would agree with that. I feel like it's everyone's responsibility to work on these divisions together. And I think that's something that we're going to be able to move forward. And it's a pretty big deal. And it can't just be the responsibility of providers and hospitals to do this. And there is evidence that jeopardizes sometimes the patient relationship. So if there's ways to find more capacity to do this, more creativity, I would like to take that opportunity.
Okay. Anyone else want to say anything?
Yeah, even I think draw an even clearer or harder line. I think before we even set up do the labor of forming a working group, I think that here should put forth bring something else to the negotiating table that's a compromise, and then look at whether we need to have some sort of small group to collaborate, because I'd like to keep this piece in. I think it benefits patients. It benefits providers who are really struggling right now. Both of those groups are really struggling. And I don't think that payers are struggling quite as much.
Okay. Brian and then Alyssa.
Yeah, I think when I said earlier, it was a little clouded by the first thing. That I'm not necessarily proposing that we put a working group in the bill. What I was trying to get at is maybe asking the stakeholders to check in with each other and some committee members like offline and see if there's, like what you were just saying, I think you just said this, like, sorry, I have like brain fog today, but like some kind of compromise. And if not, then maybe that group would say, but if we keep working together for a few months, we might come up with one. So I think before we take it out, I would at least want to try to convene a conversation of people to see if there's something we can do.
Okay.
So.
And I would say almost the same thing, is that I don't want to take it out completely, but I would like to have something in there to start this conversation that this is, as to Melanie's point, this is a shared responsibility. And I'd like to see providers and payers recognize the shared responsibility and start working on ways that possibly they can work together in making all of us whole, including the patients. And so I'd like to at least keep something in there to keep this conversation going.
Okay.
And if a small working group, that would be true.
So I think I'm going to compromise for the whole committee. I agree with all the ones who want to keep it in here, and I agree it's a big, important topic that we need to look at. But I also agree with Art and Alan that I do not want to hold up this bill for this section. So I think what I'd like to suggest is, now that we've kind of said everyone, like all these sections have to be worked on, I would like, and I'm going to look to those others in the room, if they agree, to have a group, Alyssa, Maury, maybe one other on the, work with the stakeholders to come forth with language on all of it by like Wednesday of next week, Thursday at the latest, because we do have time Thursday morning that we could review it. If that's not enough time, let me know. And that I don't want it held up for section 7. So that would be my thoughts.
So if we don't have a compromise for section 7, we move forward without it
And we-
after next Thursday.
Yeah, and we
All
can
right.
keep working on it. I mean, it's, we can always do a committee bill. That's not a problem. But I
Okay.
think the other 2 sections, we've heard loud and clear from providers that they are very important. Or the other
Say the
sections.
evil word, but I would want. I would want it to be acknowledged. And if it's only acknowledged with a study or something, then at least it's still in here.
So that is a proposal that you all, whoever's working on the committee can come back with. Yeah.
So we don't lose that momentum. Yes.
So when you say a committee, yeah, so for specifically for section 7, would you like a bunch of people to get together and be like,
So that's the question. So I'm gonna look for Alyssa and Mari because you 2 are the ones, like, can you do all of the sections with the stakeholders? I'm gonna look at the stakeholders. I mean, it's all the same people.
Yeah.
So I feel kind of weird saying like 2 people work on this one and 2 people work on this one. and-
Yeah. Let's be efficient. Let's be efficient.
Pharmacy stakeholder in too, like even
So-
one person.
Okay, I'm gonna throw out something else. I'm okay with you throwing a pharmacy stakeholder person in. I don't want that to hold up sections, the other sections either. So I want to be clear about that.
Yeah, it's just for the thing that we're also working on in the other bill, and maybe we can
Right.
get to a decision before we have to deal with it again in the other bill.
But if it's holding up progress on this bill,
Heard.
we will put it in the other bill potentially.
Yeah.
Okay. Because it's, and I think we've heard from the stakeholders at the table, like pharmacy is different. And we might get to more of an agreement on everything that isn't pharmacy and have to continue working on pharmacy. I mean, there are going to be things that this can't get to. I'm hopeful, but the intent is to move it. Section 7 can move, great. There's some type of working group, great. If we can add pharmaceuticals, great. If we can't, that's great too.
You know, we do a separate pharmaceuticals bill.
Okay. So I just want to open it up to everyone on the sidelines. If you have concerns or comments or you're comfortable with our path forward, and Jordan who's on the screen. Okay. And so it will be VAS, VMS, Blue Cross Blue Shield, Health First, FQHCs, and VP. That's VAS.
Oh, what do you call it?
VAS.
Association.
Say it.
Vermont Association of Hospitals.
Okay.
The hospital and health systems.
Yes, yeah, but,
You should wear a flower.
okay, hold on, folks, hold on.
I'd be happy to join as well, and but specific to the copay accumulator adjustment program. We decided that it didn't make sense to have that conversation in the context of this bill. I think, given all the stuff in that section, and recognize that we are actively pushing for it. We're gonna push for it on the Senate side on a bill that's coming over this way, and we also have the language. There's enough other vehicles for that conversation, I guess is what I'm saying.
Okay. So Alyssa, Mari, are you still comfortable?
Yeah.
That is expanded, and is there another member that wants to join?
I'm happy to do it, but I didn't know.
I ain't been around that long.
Or,
Yeah, you can learn. This could be a chance to learn.
I would add that I'm willing to start that thing.
so,
Go for it.
You can save me.
I think you should. I think you should. I think you should
Should do what?
work with them.
Yay.
Say yes.
You did say that.
Thank you.
That's a qualified year.
Okay.
That was not enthusiastic consent though.
So I am gonna say, so tomorrow, and the other folks may not have this time frame, but tomorrow we were gonna have this conversation. So tomorrow morning, we'll do the EMS walkthrough of the bill, and then we won't meet again until 1 o'clock to give the group some time to connect, whether it's just you guys or everyone or a partial group. I know, end of day Wednesday or Thursday morning is a tight timeline, so if you're having difficulty, just let me know. I don't want to rush this. I want to get it right.
What time is that you're
Yeah,
thinking?
tomorrow morning, when?
So tomorrow morning after the floor, we're doing the EMS walkthrough, which won't take very long. And then you guys can be free until we have our joint session at 1 PM.
Okay, so then take off Department of Corrections also.
Yes, yeah, we'll take that off.
For now, right?
For now, we will come back.
Come back, please.
Right, right.
All right, so thank you, everyone. If there's concerns, please bring them to me. Otherwise, I appreciate the path forward and we will try to make everyone a little bit happy.
Can I ask you a question before we go? This is about the Healthcare Workforce Strategic Plan Report, which we're doing the afternoon. And I know that Auditor Hopper had a report as well.
Yes,
Is that still relevant or?
yeah, he'll be going over the report. I did.
His report.
Yeah, I did send it to everyone. If you can't find it, let me know.
Is he coming in?
He's coming in,
Oh,
from
good.
my understanding.
Okay.
And then, so he did a report, and then in the budget last year, we required JFO and Ledge Council to do a
The
report.
two separate reports, I got it.
Yes.
Yeah. Okay,
Yeah.
got it.
And so they'll be going over both. And then in the report from JFO and Ledge Council, VSAC, AHAC, and VDH have made recommendations on workforce, healthcare workforce programs that we've had over the years. And so we'll hear what those recommendations are.